see. I don't like the transcript part. Okay, so this should be recording, and we'll give it maybe a couple more minutes. I will do my typical housekeeping comments. It's really dark and dreary here in Ohio, so the and there was something weird. Actually, I'm not sure if Summer's in here, but I thought there was something weird about how the AI notes start interfering with things when you have presentations. Do you remember that, Mary? Summer had said something about how the ACVNU isn't doing AI notes anymore. I'm not sure if it affects us, but
yeah, there was something about that. And I don't remember what the problem was.
It's just from saving it.
Oh, sorry. There's a lot of beeping stuff. I can't hear it. Here we go.
It says from saving the videos per JD.
Oh, so but if we want to save these, then we can't do that then. Correct? That makes
deny it. Sorry, we got a cat.
No. Yeah. I understand. I guess maybe I'll see if I can reject it then. Let's see if I can get rid of it. And nope.
No, I
know. Well, Mary Nabity, would you, I mean, I don't know if you have the possibility of changing that, do you? They're already in the meeting, the AI bot's already in the meeting.
I'm not sure how to do that.
Yeah, I don't know either. I mean, I guess maybe if it doesn't get recorded. I thought we've had them before. I just don't know what the scenario is. I just know that Summer had mentioned that about that. So, okay, sorry, we're talking a little bit about issues that have arisen from other meetings, not necessarily this meeting. So, I hear my larger dog Henley coming up the stairs. So, in just a moment, I'm going to go let him in through the door unless he opens it himself. He has heard me talking, so he knows that we have moved from downstairs to upstairs. Today, oh, he opened the door. Look at him. You're so smart, big guy. It's almost like you do all the concentration of the kidney. Okay, so, today's case, it sounds like Steph is a little busy and she's the one presenting the case. As we let people,
I'm forcing all of the interns to present in my stead. So one of our specialty interns just is logging on now, and he's going to present the case.
Got it. Okay, cool. So we have a couple of housekeeping things, which I always mention, is if you've noticed you have not gotten an invitation in a month or two, please send me an email, because sometimes people get knocked off the invite list and we don't know how that happens. We have started switching the recordings from the previous location, and we have moved them onto the ACVNU YouTube scenario. And so Summer has been moving those over for us. And so I think we have like 5 or 6 now. Each one has a little blurb about what case we're discussing. And so if you want to rewatch previous rounds, they should be available. We're trying to go through all of our backlog to make sure that as many of them are transferred over as possible. So that's number 2. Number 3 is that for those of you who submit kidney biopsies to us, I will admit we have gotten quite a large caseload in the past 2 months. It's been a little overwhelming. And Dr. Lees is doing a little more, I guess, passing on the torch for creating those reports. So he'll still be involved in any of the complex kidney cases. And writing the histories for anything that's a little more complex, but for a lot of the basic ones, I'm writing the histories for them. That means that some of them might be annotated as please refer to the history on the submission form. I will try to get the pertinent details in the history. And then the format of the report is going to be a little bit different. So you'll have the biopsy diagnosis, you'll have my or the pathologist interpretive comment, and then below that you'll have all of the images and the descriptions with the EM, the immunofluorescence, and the light microscopy. We are also kind of decreasing the number of images we put in per case. We don't really necessarily think we need 12 light microscopy images, just to, again, make it a little bit more of an easier workflow and for getting those reports out in a timely manner. Obviously, if something warrants a lot of photos because of the complexity of the case, it will get a lot of photos. But for a typical amyloid case, I don't necessarily think that everybody needs 12 photos of amyloidosis. So you might see a little bit more of a brief report as your final document. If you have any feedback about the changes, we're flexible. We have kind of discussed this with our frequent users, and they seem happy with this new scenario. But if you have more thoughts about how we could make it more efficient to make sure that the reports get out in a timely manner, please send me an email. Okay, I don't think there's anything else housekeeping wise. I'm going to turn off my camera for a moment and we're going to discuss. I think you should be able to share screen. Anybody should be able to share screen. For some reason, my more is not letting me do more actions. Okay, I am going to turn on my camera. Who's the person that's going to present stuff? Let's see. Am I on?
You are on. We can hear you.
Okay, I don't know what's happening. It's just being very weird. Okay, so Steph, can the person?
It looks like she's still here.
Yeah,
Steph said
I
she
think
was.
Dr. Skinner.
Oh, is it Mario? Or are you the one that's going to present?
Yeah. My name's
Okay,
Dr. Burns. Dr. Skinner, I think, might be a little bit busy with our dialysis case, but I can sort of take it from here.
Are you allowed to share screen?
Yeah, I think so. Let me check.
Okay.
Oh no, actually, I think I need wait, give me one second.
It's not letting me. Sorry, this is being a very weird day about as far as letting me use Teams. So when I go to my more actions, it does not even show what I'm allowed to do. So Jess or Mary, do you have the more buttons?
Yes.
Yes, I do.
Okay, can you click allow? I might have to hop off and hop back on.
I don't see an allow share.
I don't know that
settings.
we've got access to do that.
I think.
Got it. Okay, we can see it now.
Sharing?
Yes.
Yep.
Yeah. Okay. Perfect. Sounds good. Let me see if this works. Okay. Does that work?
Perfect.
Perfect. Sounds good. I don't have the Teams app available to me, so certainly if you have any questions, feel free to jump in. I'll try to kind of go ahead and present her case in a sort of concise manner. We can kind of take it from there. So once again, my name's Dr. Burns. I'm one of the specialty IM interns here at Friendship Hospital for Animals, and had the pleasure of working with Dr. Skinner, Dr. Foster, and a variety of clinicians during this case for Hazel. And so we'll get started for here. Hazel was a 9-week-old female intact German Shepherd who presented to us for lethargy and anorexia really soon after the owners adopted her, actually, kind of a week and a half. She previously had received just her basic vaccines, and then soon after, once the owners were still getting acclimated to her, start showing these clinical signs. She certainly did behave like a general puppy overall, and then experienced those findings there. And so during presentation, our urgent care service did perform blood work, which the findings were pretty significant. Just to note, she had the kind of previous puppy findings. Well, I'll just skip over them. But the most significant ones were a very severe kind of cholestatic hepatopathy of 6.2, severe azotemia, and then also severe thrombocytopenia. Because of these findings, there was a high suspicion, of course, for leptospirosis, and then further testing was performed during her hospitalization, and ultimately, during her treatment, it came back positive for lepto. And so initially, she was kind of hospitalized with supportive care, antibiotics, and IV fluids. But then there was a further concern of her becoming anuric, and that's where kind of the nephrology service got involved, where dialysis was ultimately recommended, and then Hazel was dialyzed with us. And so a total series of 13 IHD treatments were performed on Hazel before ultimately kind of considering euthanasia for her, more so out of quality of life concerns. And then here are some of the kind of results based on her treatment, just on those 13s. We ultimately were able to do a outpatient treatment option for her hemodialysis. So she stayed hospitalized for about, I want to say about 10 days or so, and ultimately transitioned into outpatient treatment to come back for hemodialysis. So here are kind of her creatinine trends with her treatments, and then here are her blood urea nitrogens as well. During her treatment, approximately kind of 1 month into it, we did experience some complications, primarily we think as secondary to her chronic uremia overall, where the owners reported at home that she was very lethargic and also had some increased episodes of respiratory increase. Her appetite was not really the best. And so one of the first things that we noticed was her increased breathing actually during her treatment. When we went ahead and further interrogated these findings observed during her dialysis treatment, there was a concern that there was a very kind of mild but developing interstitial pattern within her lungs. Our radiology service weren't quite sure if this was just more so positioning for the radiographs, but there was a concern for uremic pneumonitis overall. I think the most striking finding was in her stomach, which it's a bit of a. I hope that the Teams application can carry over the quality, but if you look at her stomach overall, you can certainly see the calcified rugal folds, and so that is a very striking finding. Overall, we're not quite sure if she became clinical for that calcification in her rugal folds, but her appetite overall wasn't the best even before that. So quite unsure about that, or what part it played during her nutritional support. And then one of the most interesting findings in her was that she did develop ultimately a reactive polyarthritis, actually, which was quite marked overall. Post-mortem, when we did sample those joints, they were very fluid and not as viscous as we would think about in terms of just normal joint substance overall. Initial treatment with glucocorticoids were performed initially at 0.5 mg per kg, but ultimately was increased to 2 mg per kg. That did improve her to some extent, but we didn't really see a significant improvement. One more important point to show is that at that point, we also did run a C-reactive protein, which came back kind of in the high normal events, but not significantly increased as well. And so ultimately, because of the polyarthritic finding, and then the owners also noting that she was severely painful at home, where at that point she could not move, she still sort of behaved like a puppy, but certainly needed a ton of support, they ultimately did decided to euthanize her. That's all I have.
Okay, thank you for that. I was able to hop on and hop back off. Hopefully everybody can hear me again still. Good?
Yes.
I can now at least now access more of my buttons than I had before. So that is the step in the right direction. I'm going to put a question in the chat. This is more for the clinicians that are in here. I guess she was diagnosed at what age with lepto? How old was she? Like a month almost?
She was about a month, and actually, no, she was 9 weeks, so she was about 2 months 1/4.
Okay, because I think she was almost 2 months when she was euthanized. Maybe 2.5 months. Okay, so I'm just curious. I'm going to put this question in the chat for clinicians to say of you have diagnosed leptospirosis in this age group. I guess this is a less than 2 months. Okay, cool. So that's more, not 2 months, 2 months. So any of you guys that are, are there any specific? Okay, so as I'm going through this, I think that this kind of is an interesting question about the infection that was proven. I mean, it was documented that this patient had positive lepto infection, not just a possibility or a concern for it. I would admit that a lot of the younger animal samples we get through the IVRPS do not have the definitive positive infection. They might have a veterinarian that suspected that that might be an issue in a juvenile dog, and I'm thinking all the juvenile ages, so maybe I've been up to like 2 or 3 years. But in general, we don't often have such young dogs that we are worried about it. Obviously, exposure is a little strange, right? Like, because you can get it congenitally, especially in certain species. But I don't know if this was more of an environmental or she had always had it since birth. And that maybe the infection was only recognized, you know, at that group of age. So I think this is an interesting kind of clinical question for you guys, you clinicians. I'm going to try to share images, but like I said, I'm having a little bit I want to share my screen, and I want to share this one. Let's see if not that. Window, that's what I want to do. Okay. Hopefully you guys are now seeing an echo of me all over the place, and then eventually now maybe you're seeing a histopathology slide. Can somebody verify? Okay, cool.
Yep.
Okay. So these samples came with the entire kidney submitted to us. Both kidneys actually were submitted to us for this case. And so the histopathology is quite striking. And I'm just going to kind of do a little bit of a survey for you guys, first of all, so you guys can get a view of what might be of importance for this particular case. And I'm also going to admit to Steph and the team at Friendship that I've sent you the final report. I think what we're going to do for this particular case is the next time Texas A&M needs to send grids to me, they're going to go ahead and send me this grid as well. And I'm going to rescope it on our EM scope that allows me to measure more things. So I think you'll probably soon get, not soon, but maybe even at the beginning of the next year, get an addendum for this case. So don't think that whatever is said here is set in stone. So that's just a warning for everybody. But I'm going to tell you that this is a glomerulus. And it is recognizable that there's a capillary tuft and that there is an outlining Bowman's capsule. This might be more identifiable as a glomerulus. And some of them have more dilated Bowman's capsules as opposed to other ones having synechia and other ones having almost kind of large regions where the glomerular tuft is adhered to Bowman's capsule. So Jessica Hokamp or Mary Nabity, can you pick somebody in the audience for me to ask a very simple quiz question for?
Yes.
You can even pick Mary Nabity if you like.
That seems mean. Rebecca Conkin.
Dr. Conkin, are you able to speak?
Yeah, I'm here.
I'm asking you a very easy softball question. Even with this H&E, do you think this is hypercellular glomerulus, hypocellular glomerulus, or normocellular glomerulus?
Can you pick a different one?
Oh. Has it been a hard day for you?
It's always a hard day for me.
Hard day for you. And I'm not talking even which in region I'm asking. I'm just in
Yeah,
general.
I mean, it looks
cells?
kind of looks kind of normocellular. I don't know. There's like 2 or 3 nuclei per loop, which is what they're supposed to be, right?
Yeah, for that part. What do you think about the mesangium, though?
Yeah, the mesangium looks a little hypercellular.
Yeah, so there's, Becca's right, Dr. Conklin is right, is that we have a pretty good capillary loop and we just have a few circulating cells, maybe even one of the endothelial cells in there. And then the mesangial cells, they almost kind of look like they're having a very, like an expanded mesangium with mesangial cell proliferation that kind of gives it almost like a lobulated pattern. Like here you have a lobule, here you have a lobule, etc. So there
and the podocytes
are
really large around the outside too, right?
Yeah, exactly. So the glomeruli in general, some of them, like this one might be considered normocellular. Maybe we don't really have as many cells as before, but if we look at a lot of them, that mesangial expansion is kind of striking. And then if we look at the capillary lumens, it is less identifiable in those regions. And I would say even maybe absent as far as that. So how do I know to say this? That the capillary lumens have a normal amount of nuclei in them, whereas the mesangium has a very prominent amount of nuclei, depending on which region you're looking at. Dr. Hokamp, can you pick somebody else? We have I saw Nav messaged on there, so I know he's available for a discussion.
Well, then Nav it is.
Nav, are you able to speak out loud, or are you only able to put stuff in the chat?
Unfortunately.
I don't want anybody to dread this. This isn't actually I don't care if anybody gets it right. I just want to be able to talk to somebody. Okay. I'm going to ask you another quick question about what you think the interstitium looks like. So do you think the tubules are back to back with one another, or do you think they're separated?
They look pretty, it looks like there's a lot of, like, I don't know, purple hyaline kind of material kind of between them.
Okay, great. So we have material that is separating tubules from one another. This might be kind of a hypertrophied endothelial, like a vessel right there. But if we look at this area, we have a tubule all the way over here, and I'll even draw a little circle around it, although I'm really bad at drawing circles with this app. Okay, sure. And then we have to go all the way over here to get to the next tubule. So, so you can see that there's quite a wide separation of the tubules from one another. And the reason I'm asking it based on the H&E stain is that there's a lot of nuclei in here as well. It's not just straight collagen. And we'll look at that a little bit more on the stain where we look at collagen for. But for this particular stain, there's a lot of inflammatory cells and probably a lot of fibroblasts in here that are separating the tubules from one another. So we have a lot of interstitial disease. We have tubular degeneration. These tubules also themselves don't look very healthy because they have kind of lost their apical surface of the tubular epithelial cells. And then we have evidence of glomerular disease. I'm going to go ahead and be very nice to you and point out that this right here is a podocyte that has a lot of abundant protein in its cytoplasm. I know it looks like it's in the mesangium, but this is kind of where a capillary loop was ending. So we have a podocyte there, and we have another similarly damaged podocyte all the way over here. And so even within one glomerulus, we have 2 podocytes that are undergoing degeneration and have prominent protein droplets in their cytoplasm. Does anybody have any more questions about the histology images we've shown so far? Here's a podocyte right here that's probably dying. He's probably detaching. So he's, given up the ghost and decided it's not worth it anymore, and he doesn't want to take on any more roles or any functions. So he's probably going to detach and fall into Bowman's space. These are probably a little maybe eosinophils in here, which is a little strange, but that's a few granulated cells in here. So everybody, I'm going to quickly go back to the screen. I would like everybody to raise your hand if you think this is an abnormal kidney for a 11-month-old dog. Raise your hand on the app. Okay. Okay, we got some votes here. Great. Okay, so for those of you who are able to vote, we think this is an abnormal kidney for an 11-month-old dog. Perfect. Great. I'm going to move on to the next stain. I do want to keep track of time, which is not normal. Okay, so the PAS is a lot easier for us to assess cellularity. It is usually the first stain I put on or I pull up when I'm looking at a slide. And so hopefully this stain makes it a little bit clearer that, although it's a little tiny blurry, but that there's usually fairly open capillary lumens with one nucleus. Here's a gray endothelial cell nucleus just sitting on the base of the mesangium, and he's maintaining this entire capillary lumen. But that when you go into the center of the glomerulus, you have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12 nuclei in this little nodule here, this little mesangial cell region. So the cellularity is prominent, and when it's present, it's most likely in the mesangial zones. And then what we were talking about previously with the podocyte lesions, with the podocyte droplets and detaching podocytes, this is a good example of it on a PAS. This probably was a podocyte originally, and he has some protein droplets because usually they're bright pink when we're looking at the trichrome, and he is probably detached. He decided to die, and he kind of got stuck to a parietal epithelial cell. Everything I tell you is a story, so I apologize if I personify the cells, but that's the way it makes sense for me to talk. This is actually, I'll quiz Mary on this one. Mary Navity.
No,
Okay.
she said no. She's eating
Oh.
lunch.
Oh, it's okay.
okay.
You can talk and eat at the same time. I just want to know, what do you think about this particular region right here of the glomerulus? What would you call that region?
Yeah, it looks like a crescent.
Okay.
Is that right?
It's not. I'm glad you tried. This is a region of segmental sclerosis that's adhered to Bowman's capsule. If it were a crescent, it would have much more, like, it'd be paler on the PAS stain, and that's just why it takes practice as far as interpreting this. And I'm very glad you answered because it shows that none of us really care if anything's right or wrong. We just like to talk. So this is a region, like this probably here is a capillary loop, and this was a region of the glomerulus that has undergone solidification. Oftentimes we'll say sclerosis, we'll say scarring, loss of glomerular capillary loops, effacement by matrix. All of those things imply the same thing, which is glomerulosclerosis. And that happens when podocytes have died and podocytes have detached. And so then once that region undergoes sclerosis, and basically it's just a naked region of a glomerulus, like no podocyte sitting on top of it, it will have a large synechia along Bowman's capsule. And so this one's kind of a broad synechia. And then if you look at the other portion of the glomerulus, yeah, we have that same mesangial hypercellularity, but we really don't have anything going on in Bowman or in the capillary lumens. It's not as prominent. Let's see if I can do any more things. Here's more. Oh, here's a good one. A region of sclerosis. So you don't see any capillary lumens in this area. It's basically a solidified portion of the glomerulus. There are too many cells in here, and it's probably mostly because the mesangial cells are so prominent. And then we have podocyte injury here with these protein droplets. We have this first beginning region of a synechia kind of from that sclerotic segment. This part is a little bit out of focus on the scan, but hopefully you can see there's another small region of sclerosis and glomerular adhesion, so a synechia as well. That is kind of repeated throughout the biopsy, or sorry, the autopsy specimen. The PAS is really good in my perspective, actually everybody's perspective, at highlighting tubular injury. So a PAS should really have good epithelial cells with a very good kind of pink brush border. And when you start to see open spaces, you worry that the epithelial cytoplasm has kind of sloughed off and been released into the lumen. And then also the other hint that the tubules are injured is you can kind of see this multi-lamination or this wrinkling of the tubular basement membrane, so that even though the tubule epithelial cells are back to back and they're right next to each other, and you don't really see that kind of open lumen like you see in this damaged tubule, it's probably because there's so much like collapse of the tubule itself. So the wrinkling of that tubular basement membrane shows that this is actually kind of undergoing atrophy. He's probably already gone past the stage of degeneration. Now he's at this atrophic stage. So a lot of that is a lot easier to see with the PAS than you would see with the H&E. All of this fragmented region and stuff here is going to be mineral. I think we ordered Von Casa on this one. I can't remember. But all this stuff here is mineral as well in the, basically like tearing apart that tubule. Any questions about the PAS? No? Okay. Okay. The trichrome is great because that's going to show us how much fibrosis we've already had in this 11-month-old dog. So in this way, we can at least give some solace that this was a very damaged kidney that was going to have a difficult time to return to function. So that the owner knows that they made the right decision, because all of this collagen that is separating these tubules from one another, so there's already this huge region that's separating these tubules from one another, that's never going to go away. And then if we look at this area, not only are the tubules far away from each other, they're also far away from their blood supply. So if I annotate that, I want to do this. Let me do this little box there. Okay, so if I annotate this, that area is where the tubule needs to get all the way. His blood supply is so far away from him that he is going to have a difficult time being oxygenated, but then also getting rid of the stuff that he has reabsorbed to put back into systemic circulation. So a lot of stuff is going to be maintained in tubular epithelial cells that shouldn't be, and they're going to be poorly oxygenated because of this distance to the peritubular capillary. And this is very this dense blue collagen is not going to go away. It's definitely deposited there for the rest of eternity. However, there are areas in this trichrome which are paler blue, and that represents more of a edematous collagen. So if we had survived this scenario and the animal had gotten better and whatever insult was gone, these things would probably kind of get closer to one another because all that edema fluid should go away. So it kind of depends when you're looking at an actual biopsy sample, not just an autopsy sample, but when you're looking at a biopsy sample and you're trying to score fibrosis, you need to make sure you're scoring the actual dark blue stuff and not the pale blue stuff. Just to make sure that you're looking at stuff that's true collagen and not just edema separating previously deposited collagen fibrils.
Hey, Rachel, Dr. T
Yep.
had a question about
Yes.
tubular atrophy versus ATN, and how maybe, I don't know if it's how to distinguish the two, or just if you could tell ATN better on the trichrome.
Yeah, so oftentimes, sorry, my nose is running. I'm having an allergy attack. But oftentimes they kind of go hand in hand. It's very uncommon in a biopsy that we get for medical renal disease where you just have ATN and you don't have kind of the ongoing tubular degeneration and tubular atrophy. Oftentimes when we see just ATN, it would be like a toxic case or an ischemic case. And that basically means like every single tubule is just necrotic. I think Friendship has sent me a recent case that was an autopsy case that truly is ATN and nothing. Like we know when the time point hit, we know that nothing had undergone, a second chronic insult. So oftentimes what you'll see, especially in my reports, is that all the things are happening at once. Whether or not I often use the word necrosis is kind of basically my mindset for that day. But the wrinkling of the tubular basement membrane on the PAS, the attenuation of the epithelial cells, and then the amount of fibrosis that encircles the tubule. So like this is an attenuated epithelial cell up here. You can see he's really stretched out over this region of tubular basement membrane. So that particular one is probably undergoing atrophy. This one is probably undergoing fairly recent, ongoing degeneration and necrosis. And we even have slough cellular debris in the lumen. So oftentimes they kind of go hand in hand. And it would be uncommon for a lot of the samples that we get, which are basically chronic, proteinuric kidney disease for our biopsy samples, where you only see ATN. We often see everything together, kind of mixed in together. Although we do have a paper, I do work with a researcher who has a paper, which I find very interesting, and I'm on the paper with him. But if you actually look at, this is an aside, this is just for like interesting standalone points about tubular degeneration and then necrosis and then regeneration. So if you look at the amount of DNA that is involved in a kidney, and we're talking about experimental rodent models at this point, and you have a one hit, and so then you wait for the amount of days, the 10 to 14 days when the tubules are supposed to regenerate and be back to quote unquote normal. The amount of DNA, if you do time points, never changes over that time period. So the replicative ability of these epithelial cells to heal themselves is quite regulated, and so there's not a point where they like basically overproduce and make too much of themselves. And so it is kind of interesting to see how what these cells are undergoing, because a lot of these are probably just actually undergoing degeneration, and they're not undergoing multiplication to regenerate. They basically have survived the insult and then are now able to reestablish themselves. And so they basically are just now like survivor cells and not necessarily post-death replication. Does that make sense to anybody? Did that sound weird? I'm on the paper. I honestly have challenged him because I can always see mitotic figures in these regenerative tubules, but apparently according to cell fate experiments, they don't actually do that much mitosis in animal models of rodents. So, okay, there's that.
It is surprising.
Yeah. Okay, so let's look at quickly the silver. Oh, no, that's that one. Oh, maybe we don't have the silver, or maybe I just didn't load it. It probably just didn't load. 1 second. No, that's back to the H&E. Oh, maybe the silver didn't get loaded. Okay, so either way, oh, here it is. 1 second. Basically, when we're looking at the silver, we're looking at the glomerular basement membrane to see if we have evidence of remodeling. This was kind of a weak day in the lab for the silver, but also there's a lot of black that kind of overwhelms everything else. So all the black in here are the nuclei, and so that's all the nuclei of the mesangial cells. And then if you look at the peripheral capillary loop, it's not definitive remodeling in any way, shape, or form. So we have kind of a normal capillary lumen, a normal capillary wall at a lot of them. So I'm not seeing a lot of spikes. I'm not seeing a lot of holes. And again, sometimes that's based on the staining quality that day, but if this had been really, really remodeled GBM, it probably would have been a little bit easier to highlight. It's not identified in the Jones stain. And that's all we use the Jones stain for. Okay, so I'm going to open up the EM stuff with my EM stuff. Okay, so I decided to do EM on this. And I think it's probably going to be easier just to go from the report section. We decided to go ahead and proceed with EM, even though it was an autopsy specimen, because we were curious about the amount of glomerular damage associated with what was going on in an insult that's usually supposed to be basically infection of the proximal tubules, acute tubular necrosis, and interstitial nephritis. That's traditionally what lepto causes. You have a pretty prominent interstitial nephritis. In certain stages, it can be more neutrophilic. In chronic stages, it's more plasmacytic. And then you have a lot of tubular epithelial degeneration, mostly of the proximal tubules, but usually the glomeruli look normal, and in most of our traditional lepto cases. So we went ahead and processed EM, and this is an interesting case because we had been concerned based on the amount of hypercellularity that maybe there were immune deposits somewhere. And so we were wondering if we were going to see any kind of electron dense deposits in the glomeruli. I'm going to tell you that what happens in puppies is that they have a very thin, normally very thin glomerular base membrane. That's normal for a puppy. This is quite thin, but as this dog would age, this would get to the normal thickness, which is about 180 to 250 nanometers. And so this is probably 1/3 that normal thickness. And we can see that, excuse me, I'm having a little problem here, that the capillary wall in certain regions starts to have this kind of irregular outer contour, and it's very mild. So the, oh goodness, I didn't mean that happen. That's not what I meant to do. I apologize. Go back to what I wanted. I'm sorry. Always show sidebar. Okay. Ah! I don't know how I did this wrong. Okay, I'm just gonna keep zooming in. Although it's not letting me move. 1 second. I'm just gonna close it and reopen it. When in doubt, reopen. Okay. So we're focusing on the walls of the capillary loops, and it should be a normal straight electron dense band. But this one has tiny little kind of elevations at the surface. We see regions where the podocytes have effaced foot processes, so their normal, beautiful, intact foot processes are not identifiable anymore. And then so all along here, this would probably be a fairly normal thickness for what we would expect in a young dog GBM, this kind of dense dark line. And then up here, we have effacement of all the foot processes along that region. And then the kind of all throughout that capillary wall. And then these are the tiny little projections that we're seeing that are going outwards. So it almost is continuous with the GBM, with the normal lamina densa, and it makes these tiny little projections outwards. Do we know the significance of this? No. We have seen a lot of, not a lot of, we have a cohort of dogs that have abnormal GBMs that are not Alport dogs. So we kind of mentioned the possibility, first of all, since this is a young dog, that maybe this is a type 4 collagen mutation that had been present way back when. I mean, obviously present at conception. And then the secondary infection made everything worse. But this is the capillary loop that is quite interesting to me, and we didn't really get a good image of it. But here is our endothelial cells, and then you have to go all the way out here to your podocytes. And so if you can see that there are a few capillary walls that are severely damaged, and then you have these other ones that have these very minor elevations. So in the disease which we know of as being a type 4 collagen mutation, the how do I want to say this? The traditional type 4 collagen mutation dogs that we identify through our biopsy service are young male dogs, and this is a very young female dog. And so the multilamination is very early, and then as the true type 4 collagen mutant dogs, so the Alport dogs, as they age, as the male dogs age, this gets very prominent, and it can be quite a wide GBM, almost similar to what we saw in that previous image. So it would be like almost every single glomerular base membrane looks like that, and even more multiple lamina throughout it. So I don't necessarily think this is the same as what we see in type 4 collagen mutation, but I wonder if there had been a primary underlying abnormality in the GBM, whether it be laminin, whether it be any of the glycoproteins or the proteoglycans that make up the GBM. Possibly, maybe this is just a carrier female dog that was had that abnormality to begin with, and then secondarily got infected with the leptospirosis. And so then when all of the secondary tubular necrosis that happened with lepto, these glomeruli were potentially or prominently at risk for more further damage, and that's why we're seeing all of that podocyte injury. Dr. Lees also makes a very good point in his comment for this report, was that this also is a dog that has had, 13 dialysis treatments. And so we're not entirely sure what could have happened during any of those treatments and whether there had been previous hypertensive episodes, which we also know can affect the GBM and affect the podocytes. So this dog has a lot of other things happening and going on that we specifically aren't familiar with when we look at EM for these cases. So we know that podocytes are damaged. We know that they have thought process effacement. We know we have these tiny little ultrastructural changes in the GBM, but that what would have happened over time in this animal if this dog didn't get the secondary infection and was, going on later in life, and then develop proteinuria later in life, then maybe these little kind of small ultrastructural changes would have been more prominent, and we would have had a better hint about what was going on. Mary, do you have any comments? I specifically asked you because I already asked you about this particular case.
Yeah, no, I don't think I have anything to add from what you said. I don't think we really know for sure. And we could do genetic studies. I guess we did investigate. I don't think you mentioned we investigated the history with the clinician a little bit, and it didn't seem like there was any related dogs that they knew of, but we're going to check into it.
Yeah, I think I'm not sure as far as what that all has. I know we were mentioning that actually for a different dog as well. I'm going to make sure that stop sharing. Okay, so that you guys can't see all my stuff. Okay, so so when we get these kind of cases, and I actually do want to say, I do want to share, there is a paper that talks about exudative glomerulonephritis is the term that they use in leptospirosis. And it came out like right as we were writing up the textbook chapter for Job and Kennedy. So I put it in the chat, and I guess I can actually bring it up and share that. Let's see. Oh, Simona, do you have a question, or was that from the previous voting? That might have been from previous voting. All right, so I'm going to share this quickly, just so that maybe you guys can see this image. Can you see that paper?
Yep.
Okay, cool. So this paper is, it's in Vet Path. It came out, I think, the last fall or something, or maybe in the spring. And so it looked at dogs that were specifically from Sweden. Yeah, Switzerland. And they looked at dogs that were diagnosed with leptospirosis. And they describe more prominent glomerular changes than what we traditionally attribute or associate with leptospirosis. And so the images actually are a little bit different than what we saw. They have actually very prominent changes like hemorrhage and crescents within the glomerular Bowman space. So this little tiny thing here is the glomerular tuft, and then all of this is filled with red blood cells. This down here has both red blood cells and fibrin. I don't know if I would have called this exudative glomerulonephritis. I probably would have called this crescentic glomerulonephritis. But the images are quite striking for what's going on in these particular glomeruli. I don't think that that's similar to what we are seeing in our case. Our case is more of a glomerulocentric mesangial hypercellularity and podocyte injury, whereas their case looks like it's more like almost rupture of the glomerular basement membranes and a whole bunch of hemorrhage and fibrin being spilled out into Bowman space. But I just want you to be aware that this is in the literature. They did not do any IHC for this. Sorry, they did not do any immunofluorescence, and they did not do EM for this, unless I'm misspeaking, Shannon. I know you were the one that helped me with this review part. Let me know if I misspoke about doing EM. I don't think I see any EM. So it's not like they saw immune complexes or anything like that, but they did yeah, they said they tried to look at EM, but it was failed due to the poor quality of the blocks, which is unfortunate, right? So it's probably not a truly ICGN kind of pattern, but it does show that maybe the glomerulus can be affected more often than we typically expect in leptospirosis. So there's that factor that I want to hold on. And the other take-home point I want to give to you guys about this case is that in these kind of young animals, and I think it would be great. I think I've even said that I need to put this out as a an approved like workflow for working up young animal kidney disease. Is when you get these things that are like, it's not just ethylene glycol, it's something different. Then making sure you have information from any related animals can be extremely helpful. It might be a way to encourage them to go get a urinalysis done because a lot of patients might not actually, as a young age, have a urinalysis run. And so any type of renal disease, and I'm talking about maldevelopment, I'm talking about, and I'll answer your question in just a moment. I saw that on the chat. But, you know, following up to see, did the animal come from a breeder? If so, do you have any related animals that are, or the parents that have had previous breeds? And trying to figure out what your cohort is for relatedness can be very helpful before we start going on to these additional weird tests that we might do. And then to be clear that even if all of the related animals had been fairly normal, or I guess I should say mom and dad had been fairly normal, then you know, you can have a one-off genetic mutation that could accidentally happen in the litter. And so you may not necessarily need litter mates to be abnormal themselves. But it's helpful to know, like, are there other ones that have proteinuria? Have isosphenuria is really big for the early detection of renal disease in young animals. They probably aren't going to have creatinine or have an elevated creatinine at that stage, but because they have so much renal reserve. But those are good questions to make sure that the owner can kind of find out about that information while you're waiting for the diagnosis. And then I'm going to answer the question that's in the chat, which is,
quick comment about that, Rachel. In humans with Alport syndrome, it's estimated that about 85% are hereditary and 15% are de novo mutations.
And even the hereditary ones, it's very familial based. So it's not like there's one single mutation that hits the entire human population. It's like you can get a mutation in any one of the strands of type 4 collagen, and then and that family will have it, and then a different family will have a completely different type of mutation. It's just I guess it's just a very hypervariable region of the chromosome in humans. So
yeah, except for those few areas that have a founder effect. That's true. Yes.
Yeah, that's true. Okay, and I'm looking at the chat. Do you have a sense of normal in an anuric animal getting dialysis repeated? I do not have a sense of normal for that. Normal ultrastructural is what you probably meant as far as what the GBM could look like. And I don't. And that's another great study question for us to look into. The ones that we see, which we've worked a lot with you too, as well, as far as like the abnormal GBMs that are usually like older dogs, not Alport dogs. They're older dogs. They are usually Yorkies or small breeds, and they're hypertensive. We kind of have that kind of picture in our mind, but I don't know how many, what an animal would look like having undergone dialysis for a long period of time. Although I've seen a lot of human kidney biopsies that have undergone dialysis for a long time, and they don't have this type of abnormal GBM. So a lot of the human biopsies I see have normal lamina densa and not this kind of small, tiny little undulations. So if we take the human information with us, then it really shouldn't have that kind of multilamination.
But those humans too are probably chronic dialysis patients who are not anuric, right? And so their level of, but they probably are chronically overloaded.
Yeah, they are. So some of them are definitely anuric because they are anuric. That's why they decided to go ahead and go with a biopsy. So the ones that we're evaluating in human kidney path rounds. So it's like, oh, they haven't responded to dialysis, and we know they're blah blah blah, something like that. We know they're an FSGS patient, and so now we're biopsying to see why is it progressed so fast. And so we would have had their baseline, and this is humans again, that we would have their baseline to get the diagnosis of whatever, and then they had a second hit, and now they're under dialysis. So I've seen both, but you're right, a lot of them are chronic patients.
Thanks. I was just curious.
Yeah, I think it's going to be, I mean, a future, it would be a good future study to see, because we know dialysis in humans, which do have chronic stages, they have so many other vasculopathies that can be secondary to the dialysis. They can have encephalopathies that can be secondary or associated with the dialysis. Obviously, it's associated also with uremia. And so investigating what that might look like in a dog, which has much shorter term lifespan and shorter term propensity for dialysis, that would be an interesting question. Is Steph still here? I'm not sure if she actually had to leave. Did you have anything else you needed to comment about that case? Mario, thank you so much for presenting and putting that together. I know it's gets super busy over at Friendship, and so it's nice that you were able to step in so that we could hear the history and not have to hear all the beeping monitors behind Steph. Okay, so it looks like we're kind of up for the end of the hour. Next rounds should probably be able to happen. Let me double check what the month is and what happens in December. 1, 2, 3. It would be December 17th. So that would not hit Christmas Eve, so that's fine. I'll send out a invitation, and I'm happy to keep doing audience participation. I don't want to upset anybody by doing audience participation, but to me, it's just a little bit more than my talking into the void. So it's more for my sanity than anything else about quizzing anybody. But I completely understand, because sometimes you guys have these on and then you get called away to something. And for example, really quickly before you go, I don't know if you ended up watching last month's case discussion that we did a case with Dr. Lobato, who did the presentation beautifully. And then we went on to the pathology, and then I kind of came back to ask her a follow-up question, and she was just absent. And so she was like gone for the rest of, like, it was just her chair and her computer like showing an empty chair. And it kind of freaked me out a little bit, because I was wondering if it was like, the end of the world. But apparently they had a fire alarm. So she had evacuated and left her computer on the entire time. And she had evacuated the building. So that's why it was like an empty chair whenever we went back for a follow-up question. So that was that story. Okay, so I will see you guys, hopefully some of you, in December, if that works. Is that good?
Thanks, Rachel.
Thanks.